Mark is exactly right. The typical percentage is about 20 to 25% of the questions have some PEDS relevance, both on the board exam and on the in-training exam after reviewing them multiple times. So there's definitely a lot of information. And I'm sure as most of your talks have been this week, I've gleaned most of my information through looking at board exam, self-assessment exams, and in-training exams to come with this information. I updated each year with this year the major updates were the major portions are parts of the syndrome talks because they seem to be tending more towards knowing gene locus, and as they find more gene locus and as they find genes that cause some of these syndromes, they become more testable. They haven't yet asked you questions on those specifically, but I think it's probably in the offing. And obviously I'll be happy to talk to you questions-wise. I was going to try to divide this up into 2 sessions. I usually try to go about 60% in the first half, so to speak. Take a break, get a Coke or whatever it is you want to do at the break, and then come back and do the last 40% to wrap things up. And so I'll be happy to answer questions at the break or at the end, however things go. So I figured we'd start with neuromuscular troubles or neuromuscular problems in children, and this should go right along in your handout accordingly in the same order. Neuromuscular problems in children are not limited to what we go over in this talk, but certainly for the purposes of the testing material, the biggest topic is cerebral palsy, which is why we'll talk about that first. By definition, cerebral palsy is a upper motor neuron disease that is non-progressive in nature. Another word to call it would be static encephalopathy. By definition, it has to occur within the first 2 years of life to be qualified in this cerebral palsy category. And an injury to the immature brain, and what it does is it creates a muscle imbalance or spasticity phenomenon. It can infect both upper and lower extremities or total body involvement. There are several ways to classify the cerebral palsy. One would be physiologic, such as spasticity versus athetoid, which is more of a motion type disorder, more cerebellar based, or ataxic or mixed. The majority of the children that we see, and almost all the questions on the test, are related to spastic type of cerebral palsy. Athetoid CP kids typically do not get contractures. They have a motion disorder, and any time that they come in, it can be totally different depending on the athetosis that's going on at the time. So there's not much in the way of surgical options for athetosis. Most of the time we use bracing and therapy and hardly ever surgery for that. Almost always the surgery is related to spastic CP, and therefore most of the test questions are related to spastic CP. Another version or method of classifying cerebral palsy is anatomical, quadriplegic or total body involvement, obviously involving all 4 extremities, hemiplegic being one side versus the other side, and diplegic being lower extremities more than upper extremities. Sometimes it's difficult clinically to decide between diplegic and quadriplegic patients. From testing purposes, by definition, a quadriplegic difference is that they're not ambulatory. Diplegics have ambulatory capacity, but their lower extremity spasticity is much more significant than their upper extremity spasticity, which makes it a lot easier from a testing purpose than it is actually managing the patient. As far as management options are concerned, you kind of need to think about these 4 options. Physical therapy, which is a starting point with these patients typically, includes the range of therapies for stretching, lower extremity, upper extremity, occupational therapy, things for functional gain. Bracing and orthotics would be the next step up. Most commonly used braces would be AFOs or ankle-foot orthoses. And then spasticity control would be the next step after that, and surgery sort of as a last resort, or if we find that that's going to give them more advantages. As far as spasticity control is concerned, you have these basic 3, and this is all now very testable material. Botox, which is an injectable form, which I'll go over in more detail in a minute. Baclofen, which can be either oral medication or giving a baclofen pump and having intrathecal baclofen, and a rhizotomy, which is surgically trying to treat the spasticity with dorsal root rhizotomy in hopes of diminishing the spasticity. Botox is formulated from the botulinum A toxin, which has definitely been tested over the past 3 to 4 years as far as on your in-training as well as on the board exam. The main things you need to know about it is the way it functions. They inject Botox into the muscle, most commonly the gastroc. And it's a competitive inhibitor at the motor end plate for the cholinergic receptors. So that's why it has a finite lifetime or span of effectiveness. You put an injection of Botox in, it'll last 2 to 3 months depending on how long it takes it for it to be cleared from the cholinergic receptors. During that time, you're hoping to block the hyperactivity in the gastric muscle and allow for more therapeutic stretching or casting to gain range. So that's the principle on which Botox is used. The mechanism of action of baclofen is largely unknown. We know that it's a GABA agonist, and one of the side effects of it taken orally is that it can cause some diminishment in tone in the upper and lower extremities. Downside on it taken orally is it has systemic effects such as fatigue and tiredness, and so that's not such a great thing. That's why now intrathecal baclofen has become more of a relevant topic for kids that have tremendous lower extremity tone. As far as surgical options are concerned, the orthopedic evaluation essentially boils down to 2 basic categories. There's either soft tissue procedures, which can include tenotomies where you just insect the tendon, such as we do commonly at the adductor at the hip. Lengthenings, like we would do for an Achilles tendon lengthening or a hamstring lengthening, and transfers, such as a rectus tendon transfer or a tibialis posterior tendon transfer. Those are the basic soft tissue procedures. And we typically do those early. By early, I mean less than 5 years of age. The bony procedures are typically done for later bone development that occurs as secondary to muscle overpull or muscle imbalance issues, most commonly being at the hip with muscle imbalance causing hip subluxation. The typical exam type question for cerebral palsy involves an ambulatory child who's diplegic or hemiplegic, because that's the most readily testable option, and they can give you direct words and numbers as far as their range of motion is concerned, unlike what it is in the clinic when you have to try to figure that out just from looking at it and examining the child. For example, let's say you have an ambulatory child with hemiplegic cerebral palsy who has toe walking as their major complaint, and then they'll give you a physical exam and say that they have the ankle dorsiflexion on one side to 10 degrees beyond neutral, and on the other side it lacks 10 degrees from full ankle dorsiflexion. In general, if they're able to dorsiflex their ankle beyond neutral or 5 to 10 degrees beyond neutral, then that's a braceable foot. If you think about it, that means that there's spasticity in tone causing the overriding toe walking phenomenon, and so that's a patient that would be better off braced. On the other hand, if they have lack 10 degrees from full extension dorsiflexion with their knee in full extension, then that's a patient that has a contracture in that muscle, and they're trying to lead you towards the tendo-Achilles lengthening as the option for treatment in that child. The main disorders you see in the diplegic child that's ambulatory is a crouched gait pattern. The problem with crouched gait is that if you just address the heels, then the crouching can become worse. If you just address the hamstrings, it can become worse. It's really hip flexion, knee flexion, and ankle equinus that creates this sort of triad or triple level problematic gait issue. Gait analysis has allowed us to further discern this. It's a little more precise in its ability to tell you where the tight muscles are and how you can best address these. Multiple level releases are typically done in one sitting, meaning in one surgical procedure, to try to avoid the anniversary phenomenon where children come back repetitively over and over and over on an annual basis because they have ankles done one year, then the knees done the next year, etc. We try to do it all in one sitting. The most likely, this is a common test question, the most likely contracture to recur is the hamstring contracture. And probably that's because a lot of these kids use wheelchairs as they get older for their long distance ambulation needs and use and ambulate independently for more shorter distance or around the home. So the more they're sitting in the chair, the more their knees are flexed and the more the hamstrings can become tight. Over time, this can create an elongated patellar tendon from standing in this crouched position, a patellar alta type position, which is a very difficult problem to treat. I have not seen them ask any questions on the treatment of patellar alta, but it's definitely something that occurs in the children with cerebral palsy that are ambulatory. The stiff knee gait pattern is something that's a very testable material as well. The stiff knee gait pattern is typically in a child that's diplegic and ambulatory. The basic code words that they use are limited knee flexion and swing, difficulty with transitional movements from a chair to standing, or they'll most recently have, say, the child has some limited knee flexion gait abnormalities, underwent a gait analysis, and show you a gait analysis that shows EMG evidence of the rectus femoris firing out of phase during the EMG. All these are trying to lead you towards considering doing a rectus femoris transfer to try to get that spastic rectus muscle out of the midline during the swing phase of gait and allow them to have a more neutral or knee flexion swing during their swing phase of gait. Spine deformity is a big issue in children with cerebral palsy. Conceptually, if you think about it, the children that are more involved have more risk for spine deformity. Therefore, the total body involved child or the spastic quadriplegic child that's non-ambulatory is for sure the highest risk. This is the problem that they have. All their weight goes on this downside ischium. They don't have neutral pelvic balance or neutral spine balance, so their pelvis is oblique. And if you're spending your whole day sitting, you guys have been sitting here the whole week, imagine if you're just sitting on your right hip the whole time. And you shift around on your seat all the time. We all do that just to try to diminish the load from one seat to the other. And if you have to sit that way the whole time, that creates a problem. One thing you can do non-operatively is try to have custom seats made. But any custom seat you made is difficult because you have to readjust it as their spine deformity increases. Not to mention the fact that it's hard to diminish the amount of weight that they put on their downside hip. So the vast majority of kids, when they get that kind of deformity, if they're able to withstand the rigors of it, will end up becoming some form of a surgical conversation about how they're going to deal with their severe deformity. The surgical indications from a testing standpoint in scoliosis and cerebral palsy is a child that has a progressive deformity, not a 20-degree curve, but a curve that's gone from 20 to 40 to 50. So over 40 degrees, for sure, is a progressive deformity with sitting imbalance and pelvic obliquity. If they have a 35-degree curve and there's no pelvic obliquity and their sitting balance is excellent, they don't need a spine fusion. On the other hand, if they have progressive deformity with sitting imbalance, those are the patients that they're going to ask you on the test, and their answer is going to be leading you towards surgical treatment because of the obliquity and the sitting imbalance issues associated with it. As far as the management surgically is concerned of these children, the spinal fusion, there's excellent data now documenting that fusing to the pelvis is definitely the way to go, and that recently came out in the last 18 months in JBJS as well as in Paediatric Orthopaedics, that long-term studies have shown that if not fusing these patients to the pelvis with cerebral palsy, is more than 50% of them have to come back and have a revision extended to the pelvis because you didn't treat their underlying problem, which is their sitting imbalance. And so from that standpoint, fusion to the pelvis is definitely the answer. What technique you use, what rods you use, what screws you use does not matter and is not testable. But fusing to the pelvis is definitely testable. And using segmental fixation. They once again will not ask you, are you going to use wires, you're going to use screws, you're going to use titanium, you're going to use stainless steel. They won't ask you that. What they want to use is segmental fixation, meaning you want to have some type of fixation at each level if possible, or skipping one or two levels is not always possible to accomplish because you sometimes have a laminectomy or something you have to dodge. But segmental fixation implies you have multiple points of fixation throughout the spine. The big controversy now is whether or not you need to do anterior posterior spine fusion or can you do just posterior spine fusion alone. I have an ongoing prospective study myself looking at this very issue. My gut feeling is that posterior alone is going to be adequate, but that's probably not testable. I think that the answer now is posterior spinal fusion with segmental fixation to the pelvis is the code answer for the testing material. Spine deformity is one big issue with cerebral palsy. Another is hip subluxation or dislocation. Neuromuscular hip dysplasia would be another method of describing it in words on the test. The bottom line is you have muscle imbalance like we talked before. Typically, this muscle imbalance involves the hip adductors and hip flexors. These children have lots of tone in the hip flexors and the adductors. Creates a scissoring gait pattern commonly when you see them walk. Our goal is to try to prevent the hip from dislocating. The reason for that I'll show you in a few slides, because once the hip's dislocated, it becomes out of round, and once it gets out of round, you can't put a non-round peg inside a round hole. It doesn't work. And then mechanically it doesn't last and doesn't hold up, and then you get into salvage procedures. So our goal is to try to prevent that dislocation. This is what we mean by a scissoring gait pattern. You can see by the way this child walks through swing phase that adductor of the hip just flexes, just pulls that whole leg over across the other side in a scissoring fashion. In kids that are, excuse me, in kids that are non-ambulatory, the adductor tightness can become severe enough that perineal care, such as changing the diapers on this child, can be very difficult. So although there's perineal care in everyday activities as well as their ambulatory capacity that can be affected by this problem. Here's an example of how we typically treat a well-established or something that's been going on for a long time with imbalance. This hip on the left side here is about 85% dislocated or subluxated, and on the right side perhaps 50%. you can see that as the muscle imbalance continues, you have significant coxavalga, neck shaft angle probably approaching 160 degrees or greater on both of the hips on the left side. So the VDRO, which they have used those letters on the test, the varus derotational osteotomy is what that stands for, is definitely an option. Trying to pull those hips down into a more varus position like you can see was done here on the right side. Typically we'll try to bring the neck shaft angle down to 120 degrees or so in an ambulator, or even farther in a non-ambulator, just so that they don't grow back out of the operation again. The whole principle, once again, being trying to keep the hips reduced or located within the acetabulum. This is a year and a half post-operative, demonstrating that the hips have maintained their position. This is the reason that we do that, because a chronic painful dislocation, such as this, the head is no longer round, it's misshapen, and the socket is severely dysplastic. That is not reconstructible. Putting that hip back in the socket is not an option. They have tested on this material as well. You basically have three options in this category. Option one is to leave it alone and deal with it best you can, but they're not going to test that if they're at this point. The other two options are, one of them is counterintuitive. It's called an abduction osteotomy. Abduction osteotomy essentially means you make more valgus. So you make a laterally based closing wedge osteotomy like this to pull that hip further away from the pelvis, because the problem we think is that the femoral head rubs against the ilium, and that creates cartilage degeneration, and then subsequent pain develops just like it would in a degenerative joint. So an abduction osteotomy is one option. The other option is a proximal femoral resection, girdle stone procedure, where you come in surgically, make your cut here, and take this entire proximal femur out. They both have pluses and minuses. The downside on the proximal femoral resection is you take a stiff, painful leg and make a floppy leg. You took the whole proximal femur out, now there's no support proximally, so that leg can piston and move around. That has pluses and minuses. The abduction osteotomy, that hip is still going to be quite stiff because you still have the same length. You're just hoping that it doesn't grow back and start touching the ilium again and causing pain again. So they have pluses and minuses, and as you can see, neither one is perfect, which is why we try to keep the hip in the socket to begin with. That is the hip that I just showed you. So you can see why it's painful, and that's why we try to do everything we can to keep the hip in the socket as far as preventiveness is concerned. Down to the foot in cerebral palsy, there's two basic problems. The foot can either go into equinus and valgus or equinus and varus, depending on the hindfoot and the ligamentous laxity of the child. If they have ligamentous laxity in general underlying, they tend to go into an equinovalgus position at the foot. The reason for that is somewhat biomechanical in nature. If you have a tight Achilles tendon, as you can see this taut Achilles tendon coming down from the gastroc on both sides, it's a shorter distance from the gastroc to the calcaneus insertion if the hindfoot valgus. So if the foot collapses into valgus, and if the tendon's tight, it just collapses into valgus, and that shortens the distance, and that makes it a continual problem. The problem that these children get is then they also subsequently, that's the hindfoot deformity, they also get uncoverage of their in the midfoot of the talonavicular joint along the way. So the treatment for this is that the primary problem is the Achilles tendon, because the Achilles tendon tightness is what led to that foot collapsing into valgus. And so you do Achilles tendon lengthening, and we found over time, we being pediatric orthopedists, that doing just that is probably not enough in these children with this ligamentous laxity. So we usually add either a calcaneal osteotomy or a subtalar arthroresis, which is called a Grice procedure. I'll show you two examples that show what that means. A Grice procedure it's arthroresis with the RE because it's technically not an arthrodesis. You take a bone block, typically iliac crest, that it can be allograft. You see the talus pointing directly vertically here in this flat foot on the left side of the screen. You pull that hindfoot back into a more neutral position, and then you put, from the laterally based approach, because it's a valgus deformity, you put a block of bone in the subtalar joint in this location right here to try to block it from going into valgus. So that's one potential option. A more preferred option from myself, with personal preference, would be this, a lateral column lengthening procedure, because then I don't violate the joint, which is why I like this better. So this you can see, this child has a vertical talus, as you can see here, coming almost vertically from the tibial plafond because of the valgus positioning of the hindfoot. If you lengthen that lateral column by performing an osteotomy just proximal to the calcaneocuboid joint, lengthen that lateral column, you can swing the hindfoot back into a more neutral position and then maintain that length and not have to violate the joint. Both of these bone procedures work well if they're accompanied by an Achilles tendon lengthening. And that's something that's definitely in vogue as far as treatment is concerned for equinovalgus deformities. The equinovarus deformity, which is coming in the opposite way if they don't have the laxity in the hind foot, typically those kids have overpull in the tibialis posterior in addition to the Achilles tendon. Typically they show you a picture like this one of a child walking with this dynamic foot deformity. Most commonly they'll have a gait analysis on the test question just to show you that there's either overactivity in the tibialis posterior or not. And there's two basic treatment options for this as well. One is makes lots of sense. If you have a spastic tibialis posterior muscle, transfer that muscle, half of it, to the lateral border of the foot and lengthen the Achilles tendon to try to balance the foot like you would with the reins on a horse. Have half that tibialis posterior tendon going medial and half going lateral. Typically we insert it into the peroneus brevis so that you have a good grip on the lateral border of the foot as well. The Rancho procedure, which I have seen them ask at a test question and just say Rancho procedure and expect you to know what it entails. The Rancho procedure basically has three components. There's a tendo-Achilles lengthening, a fractional lengthening of the tibialis posterior because that's what's causing the varus, and they split the tibialis anterior tendon and take half of it lateral instead of the tibialis posterior. So those three. Lengthen the tibialis posterior, lengthen the gastroc, or the Achilles, and transfer the tibialis anterior to the lateral border of the foot to try to balance the foot. Both of them are trying to balance the foot with a soft tissue tendon transfer. So that's the main questions that you'll see over and over and over again in the cerebral palsy or spastic cerebral palsy treatment realm. So let's move on now to myelodysplasia, also known as spina bifida. It's a failure of neural tube closure. This is what it looks like in an infant. The risk factors, which is very testable, are these four: folate deficiency, valproic acid use, maternal diabetes, which is a big one, and maternal hyperthermia. Most of these are correctable and notable, and most of these now are treatable. Therefore, the overall rate of myelodysplasia is declining. It's not anywhere near zero, but in children that with our increased perinatal care, it seems to be diminishing at least to some degree, which is good, obviously. The myelodysplasia is probably the most tested neuromuscular disorder on an exam, and I think largely because they can use strict anatomical guidelines, and it can be both an anatomy question and a neuromuscular question. For example, the lowest level of functioning is how you describe the level. So if I said to you, this child is a L4 spina bifida child, just as a thought process, there's no questioning. If they're in the clinic, you say, oh, I don't know, maybe there's a little hamstring, maybe it's L4, 5, it's a bargain. Not on the test. It's either L4, it's L5, S1, etc. So then what they want to know is what's functioning. So then you have to know what's the L4 nerve root, what's the L5 nerve root, what do those do? So it becomes an anatomy question. So that's why the myelodysplasia is one of the most heavily hit areas. And if you think about it, don't let it scare you. It's a real easy question. If they say L4, yeah, tibialis anterior will be intact. If they say L5, probably have a hamstring. S1 would be gastroc. It's easy once you think about it and just say, okay, it's not really a myelodysplasia question, it's an anatomy question. The other three big things you need to know about myelodysplasia is that if they have changes in function, they're implying that spinal cord is being tethered or stretched, so you need to get an MRI. The reason that's true is 100% of the kids with spina bifida have a tethered cord. The first slide I showed you with the child with their neural elements all open, the treatment for that is to close it. Anytime you close it, there's a scar. Anytime you have a scar, there's going to be some tethering of the cord. It's just a matter of whether or not it's symptomatic. So as this child's spine grows in length, if that spinal cord's tethered at the bottom and it's growing in length, there could be changes in function. For example, if the child is an L5, the way they would test you on that child is L5, S1 level functional myelomeningocele, now comes into the clinic and is non-ambulatory, and on clinical exam is L2 level. Well, that changed function by 3 levels. First thing you have to think about is there must be a tether, we better get an MRI. And they'll try to lead you astray and say, oh, it's probably a foot deformity, you should do some surgery or x-rays. You better get an MRI to make sure there's not a tethering of the cord that needs to be released. The third thing is the IgE-mediated latex allergy. They're obviously not going to ask you if you know about latex allergy and myelodysplasia. That would be too easy. They're going to say something like the child's having a child with spina bifida is having an anterior-posterior spine fusion. During the anterior exposure, there's minimal blood loss, 50 to 100 cc's of blood loss. 1 hour into the procedure, despite the minimal blood loss, there's a precipitous loss of blood pressure, hypotension, and hypoxia. That is the latex allergy. And that's what they want you to know. It's IgE mediated. The little particles of latex form an eluent from the body fluids and then creates this IgE mediated profound anaphylaxis. So that's why 100% of the time you have latex allergies written across the whole chart of the patients with myelomeningocele, so you don't use latex gloves. The last thing that I want you to know for sure on myelodysplasia, and I'll go into some more details on myelodysplasia, is that fractures are common. And they love to fool you on the fractures. They'll say a child with L3 level spina bifida comes in with ankle pain and swelling and redness. And then they'll somewhere in their little creepy way of writing the test question say that on exam of the ankle that you can feel crepitance. Somewhere in there the crepitance word, or there'll be some instability or something will be written in there to make you, if you blow over it, you'll automatically think this is an infection. It's red, it's warm, and it's swollen. It's got to be an infection. And in spina bifida, they do get a lot of infections. But don't forget about fractures because they're insensate. If it's an L3 level, they don't feel their ankle. And so that's what they're trying to fool you on, is to make sure you don't miss that. The infection rate is alarmingly high. If you need to have your confidence brought down a little bit, just start operating on kids with spina bifida, and that'll take care of that problem for you real fast. One of the most commonly asked questions in spina bifida that has to do with an anatomical variation is, what is the most common level for children with myelodysplasia to have a hip dislocation? Well, if you remember this chart, then this question's easy. It's L3-4 because if you look at the line right here between L3 and L4, if you're L3 or higher, so if you're an L3-4 level, you have active hip flexion and active hip adduction, which when we just talked about CP, they have over a muscle imbalance. That causes hip subluxation and eventual hip dislocation. If you have L5 function, you have a hip abductor, so the abductors can counteract the adductors and balance that hip a little better. They don't typically get hip dislocations. So L3-4 is the most common level to get hip dislocations. They also can get abduction contractures. If their L5 root is stronger, they can get significant abduction contractions. That's a problem for a sitting child because they have trouble getting their hips in within a wheelchair. And that could be a big problem. So O'Brien procedure is one that's been described where you do a double lengthening of the iliotibial band, one proximal and one distal, in hopes of getting their hip abduction contractures under better control. With the lower extremity in the myelodysplasia, you want to try to keep the kids upright and ambulatory as long as you can to try to increase their bone stock so you can hopefully minimize the fractures and the osteopenic issues they have as an adult. One thing we'll use to do that in children that are L4 level, let's say, and have weak quadriceps, is a KAFO. I put that on there because they asked that 3 years ago. The KAFO stands for knee, ankle, foot orthosis. I'm sure you're getting lots of rehab talks this week too where they'll be going over those kind of things with you. But that's something we use commonly to try to keep them upright and ambulatory. Foot deformities are extremely common. If you think about it, the lumbosacral nerve roots are the lowest on the spinal cord, most commonly involved in myelodysplasia, and that's what innervates the foot. And so the foot deformities are huge and a large portion of the deformities. At least 60 to 70% incidence of foot deformities in children with myelodysplasia. They can run the gambit of club feet, which are very severe and stiff and syndromic type club feet, not the typical idiopathic club feet, vertical talus, and calcaneus foot deformities, depending on the deformity and the overpull situation. The club feet are very rigid, and the biggest problem you have to worry about with these specific to myelodysplasia as opposed to idiopathic club feet, which we'll talk about later this afternoon, is that these children are insensate in their foot. And so if you try to do a lot of manipulation on their casting, they will slough their skin, they'll get skin blisters, they'll have big problems. And so most of the time, children with myelodysplasia end up having surgical release of their deformity, a much higher percentage than do children that have idiopathic club feet. A lot of times they'll have severe rotational deformities in the lower extremities as well because of the overpull, and commonly we'll treat these with a derotational osteotomy of the tibia in hopes of obtaining a plantigrade or neutral position of the foot as possible. By far and away, the most common deformity in children with myelodysplasia is scoliosis. And if you think about it common sense-wise, why doesn't that make sense? Because they have a spine deformity. They have, by definition, they have congenital spine deformity. Their neural tube did not close. That's why they have myelodysplasia or spina bifida. So therefore, they have a congenital anomaly in the vertebra, and therefore the incidence of scoliosis is tremendously high. The higher the level of the myelodysplasia, the higher the level of the scoliosis incidence. 100% of the children that have thoracic level myelodysplasia have scoliosis. And the biggest thing to remember is that bracing is, not only is it ineffective, it's contraindicated. By definition, a congenital scoliosis is not a braceable scoliosis. You have a vertebral bar, you have abnormal shaped vertebra, there's no brace that's going to be effective in treating that. Once again, the biggest thing you need to remember is if you have any change in function, one method that can test you on that is if you have a child with a 20-degree scoliosis, it's a L1 level spina bifida, and they return in 6 months and their curve is now 40 degrees, you better get an MRI to make sure that's not the first symptom of that spinal cord tethering that we talked about a minute ago, and that's why you get an MRI for any kind of rapid progression. The treatment of spine deformity in myelodysplasia from a testing standpoint is completely non-controversial. You have to do an anterior-posterior spine fusion, and for sure on the test you have to do anterior-posterior spine fusion. To remember it in your mind so that it's not just another fact, it's very difficult to get a child with spina bifida to fuse posteriorly. They have no posterior elements. That's why their spinal cord was floating in the breeze when they were born, because there's no posterior elements. So to try to accomplish a posterior spine fusion is very difficult. So you have to do an anterior fusion 100% of the time, anterior and posterior. The pseudoarthrosis rate, even with that, is very high, and the infection rate is alarmingly high as 25%. And probably the reason the infection rate is so high is we put this much hardware in a child that has very thin skin overlying. It basically goes skin, 3 cells of fat, and then dura. That's their back. And so there's very little soft tissue coverage in that area, and so that the infection rate is very high accordingly. Another particular spine deformity associated with spina bifida is a markedly severe congenital kyphosis, gibbous-type deformity like this. That's the thoracolumbar junction, coming up in at least 150 degrees of kyphosis. The problem with this is in a non-ambulatory child is a thoracic level spina bifida. The point that touches the chair are their hips and the bump over the gibbous. So the skin is very thin because that's where their defect was. They get constant breakdown issues. And so that has been tested, and the answer for that is to do a kyphectomy. This is that child's deformity. You can see it looks like a roller coaster, about 180-degree lumbar kyphosis. Kyphectomy means you come in and you resect several vertebrae across the apical segments of that kyphosis, and then do whatever type of fixation you can accomplish and get covered to push that spine into a more neutral position in hopes of eliminating their contact point with their chair. So those are the two big issues, the spina bifida and cerebral palsy from a neuromuscular standpoint. Arthrogryposis I include in the neuromuscular category. It has specific things that are related to it that you need to know about from a testing standpoint. You may never see a child with arthrogryposis in your practice, or you may see 1 or 2, but not a lot. They typically have multiple congenitally rigid joints. That's what arthrogryposis means. The biggest thing to remember from a testing standpoint, and when you're talking to these kids, they are normal intelligence. Commonly, they will be straight A students. I think a large portion of that is because they do have their brain is fine, and they can't really do anything with their body. They can't do any kind of physical activity, so they read a lot, they use computers a lot, and they're very intelligent kids. And their sensation's intact. When you see the pictures I'll show you in the next couple of slides, if you haven't seen a child with arthrogryposis before, it's hard to imagine that a child that looks like that can have normal intelligence and have normal sensation, but they do. And the problem is that they have decreased anterior horn cells, which is the main cause of their issue. And it's one in about 3,000 live births, so it's not a very common problem. The treatment is 100% based on their function. Largely in orthopedics in general, that should be our plan, is to treat people based on their function. But specifically in kids with arthrogryposis, you have to take their special situation under consideration, the fact that they're in a wheelchair and you want to try to improve their life as much as you can if you're going to deal with them. This is what the typical child will look like. They aren't able to move their joints, so they'll have no flexion creases at the elbow commonly. The elbow will be stuck straight. The knee will be flexed and not have any extension creases. And these are very rigid joints. And these children have they can usually move their fingers slightly, but they're very much markedly ulnar deviated or radially deviated and flexed. So they can usually run an electric chair, and they usually do cruise around in an electric wheelchair. And they use a computer extensively. Since they've gotten more technology in the wheelchairs and the electrical ability to do it with a computer, it's a great advance for these children to be able to be more independent. But nonetheless, they have normal intelligence and normal sensation. It's usually quadrumelic, meaning it involves all 4 extremities, and they have marked limitation in range of motion. Their club feet are, just like the rest of their body, extremely rigid, probably some of the most rigid feet you'll ever see. And the treatment is solely based on these kids most of the time getting that foot to be shoeable. Especially, I mean, if you live in a warm climate, that may not be as big an issue, but at least they have to wear some kind of coverage on their foot in this area for sure. And so commonly we'll try soft tissue procedures, but unfortunately the recurrence rate is exceedingly high, and we commonly have to go back and do bone procedures, including as much as a talectomy at times, remove the talus to allow the foot to have enough flexibility to come into a more neutral position. They very commonly have teratologic hip dislocations, and this slide is on there independently for a very good reason, because they will commonly try to have this x-ray on a child with arthrogryposis and ask you, what is your treatment? And if you didn't know it was arthrogryposis, or you didn't know what arthrogryposis was, you would probably say Paediatric harness because it's dislocated hip. Sure, put a Paediatric harness on it. But that is contraindicated. The reason it's contraindicated is a Paediatric harness by definition has to have a reducible hip that's flexible and reducible. If it's not reducible, then the Paediatric harness will just be pushing that femoral head against the ilium, and it won't ever come back in, and in fact can create harm, create avascular necrosis in the proximal femur. So a teratologic dislocated hip, such as the children with arthrogryposis have, you can see this already has a pseudoacetabulum. Here's the real acetabulum. Here's the pseudoacetabulum from that femoral head being lodged up against the ilium. So it's a syndromic teratologic hip, and you cannot put that child in a Paediatric harness. The treatment options for this are either open reduction, surgically, or leave it out. Those are your two choices. Larsen syndrome is another form of a teratologic hip dislocation. This is a classic x-ray to show you on the test, and this is a 1 in a million syndrome. I mean, you see this. I have one patient today in my practice. I have him come back once a year so that whoever's rotating with me can see the child, essentially, because there's not much else to do at the current time. But they have multiple joint dislocations. In the lower extremity, you can see here, bilateral hip dislocations, knee dislocations, radial head dislocations. Cervical kyphosis is a big issue, and that's actually what they've been testing over the last 5 years. Is they'll show you a child, one time they even said a child has Larsen syndrome or has a familial multiple joint dislocation syndrome, and you had to know that those children are at high risk for cervical kyphosis, and that was on the test. And the cervical kyphosis can be devastating. So check a cervical spine radiograph or an MRI of the cervical spine or examine the cervical spine would be the answer. Duchenne's muscular dystrophy is very easily testable. This slide depicts what a Gower sign is. It's a sex-linked recessive phenomenon. They have a markedly elevated CPK and the Gower sign, where they walk themselves up their body to stand up. They have calf pseudohypertrophy. Their calf is enormously large. And the reason is they have infiltration. Instead of having normal muscle, such as you see on this portion of the slide, they have connective tissue infiltration, which gives them the calf pseudohypertrophy. The big things to know are the hip extensors are the first muscles to be affected. That's why they have to use their hands to push their body up straight on a Gower sign. So the hip extensors are the first affected muscles, the gluteal muscles. You do a muscle biopsy, and you'll see the CT, connective tissue infiltration. And the biggest, most recent thing is on DNA testing, they have an absent dystrophin protein. And that is something you need to make sure you understand. Dystrophin is a normal protein in the human body. If you do not have the dystrophin protein, if you have none, then that is Duchenne's muscular dystrophy. I'll talk about Becker's, which is a less severe form, in a minute. The children with Becker's typically have present dystrophin, but either dysfunctional or not as much as normal. So dystrophin is a normal protein. It's absent in Duchenne's muscular dystrophy. The big testable question from spine standpoint on Duchenne's muscular dystrophy is scoliosis. Children that have curves that progress up to 20 to 25 degrees, surgery is an option at that point, and that makes a wonderful ability for them to test you and then make sure you're thinking clearly. If they show you a child with idiopathic scoliosis or cerebral palsy with scoliosis that has a 25-degree scoliosis, you wouldn't think about operating on it. You would choose the option of observation, further follow-up, etc. In a child with Duchenne's muscular dystrophy, if they show you a child has a straight spine and then a year later has a 25-degree curve or a 30-degree curve, the answer is going to be surgery as an option because that's typical for Duchenne's muscular dystrophy. If you're going to operate on them with scoliosis, you should do it when the curve is small as the first sign of progression, because as the curve gets bigger, their disease gets bigger, and they get respiratory compromise, and they have more difficulty getting through the surgery. So when you have progression, that's when you operate on it. And that's distinctly different from idiopathic scoliosis. And when they ask you that on a test, they will for sure ask you, a curve magnitude that you would either brace or observe in idiopathic scoliosis, such as a 35-degree curve or 25-degree curve. In Duchenne's muscular dystrophy, the surgery is the answer. I can't say that word very good, so fascioscapulohumeral muscular dystrophy, FSH muscular dystrophy, is autosomal dominant. They have normal CPK. The biggest thing they have, their hallmark, is the scapular winging that you see, and they're unable to whistle because of their facial muscle weakness. It's the one indication that I think makes the most sense to do a scapulothoracic arthrodesis, because you take a child like this who's unable to abduct his arm, you fuse his scapula, and you can get at least up to 90 from an abduction standpoint, because it stabilizes the scapula, and that makes it more functional for them. Beckers, as I talked about several slides ago, they have abnormal or less than normal amounts of dystrophin as compared to Duchenne's, where they don't have the dystrophin protein. So therefore, it's less severe. They usually live longer, and it's sex-linked recessive. Friedreich's ataxia and Charcot-Marie-Tooth, which will be the last two in the neuromuscular section, are in the HSMN category, hereditary sensory motor neuropathies. There's now, I believe, 8 or so of those. Orthopaedically, what these cause is cavus feet. The specifics for Friedreich's ataxia is that it also causes a cardiomyopathy and scoliosis. Typically, they'll have a wide base gait because it's spinocerebellar in nature, and they have significantly rigid, high-arched cavus feet with claw toes as well. The big catch with Friedreich's ataxia is they have scoliosis and they have cardiomyopathy. The scoliosis can progress very up to a very severe form, and the cardiomyopathy is a very much an issue when you're operating on their spine, so you have to have a cardiology consult. That might be an answer, for example. If the child has Friedreich's ataxia and scoliosis, what would be part of your pre-op workup? Cardiology consult. That's one method of them figuring out that you understand they have cardiomyopathy. Charcot-Marie-Tooth, the feet look very similar to the Friedreich's ataxia children. It's autosomal dominant. They have very severe cavus feet, which can become quite rigid in nature, and obviously it's familial. The most affected muscles are these four, the intrinsics of the hand and the foot, as well as the peroneus brevis and the tibialis anterior. All right, so that's the neuromuscular challenge that you'll see, and that's very heavily hit typically on the in-training exam. The spine section, and particularly the pediatric spine, is usually 5 or 6 questions on the in-training exam and or on the board exam type question. And I'll go into the categories on how they ask those questions. It's not quite as heavy, so to speak, as the neuromuscular, but I'll go over the salient features, and I'd be happy to answer any other questions that you have. As far as scoliosis is concerned, obviously the idiopathic variety gets subcategorized: the adolescent, juvenile, and infantile. And you have to know the 3 categories because it all makes very good test material, and it's treatment-based. The idiopathic adolescent variety, right thoracic curves predominate, and left thoracic curves are rare. A left thoracic curve is usually an indicator on a test that if it's an adolescent with a left thoracic curve, you better be thinking, oh, is there something else going on? Maybe it's not idiopathic, and therefore you need to get an MRI to rule out the possibility of a cyst or a syrinx. There are 2 predominant classifications in the literature over the last 25 years. The King classification being sort of the gold standard of the past, I'll say, came out in the 1980s, and the Linke classification, which recently came out about 2 to 3 years ago. The Linke classification is heavily research, outcome, and treatment-based, and is becoming more and more the wave. To my knowledge, I haven't seen a test question at all on the in-training or the board question where they make you classify it King classification or Linke classification. That may be coming in the future, but I don't see it as happening just yet because it's extremely complicated. The biggest thing is you've got to make sure that it's idiopathic scoliosis you're dealing with. You want to make sure there's not a cyst or a syrinx. So if there's a left thoracic curve, if they have lots of back pain on a test question, if they have lots of back pain, if they have a left thoracic curve, if there's some kind of neurologic issue on exam, they're not able to walk normally, then you probably should get an MRI to make sure that there's not some other type of problem that could be potentially causing the scoliosis. The biggest factors that affect progression: the age of the patient, skeletal maturity index, peak growth velocity, curve magnitude, and curve type. The top 3 are all kind of go together. People go through their peak growth velocity in their pre-adolescent growth spurt. In females, that's usually just prior to menarche. Males are not as predictable, but they always have a peak spike where their growth goes up and they'll grow 3 to 4 inches in that 1 year. The skeletal maturity index is typically done by Risser sign, as you see on the right side of the screen here. Risser divided the ilium into 4 sections, each accomplishing 25%. 0 is no apophysis, and 5 is completely covered and fused, and everywhere in between in 25% increments. Curve magnitude, curves less than 20 degrees typically do not progress. Over 20 degrees, the progression rate jumps up by about 50%. And the type and location. Thoracic curves are much more likely to progress than lumbar curves. And double curves, meaning a thoracic curve, double thoracic curve, or a thoracic and a lumbar curve, is much more likely to progress than a single thoracic curve or a single lumbar curve. Progression after maturity. This slide right here is how you should make your decisions about how you answer the test question as well as how you treat these patients. Long-term studies have shown that thoracic curves greater than 40 degrees will continue to progress after maturity. That's why 40, and actually that number is down to 45 degrees. That's why 45-degree curves are bigger and a child is still growing. Virtually 100% chance that curve is going to continue to progress in adulthood, let alone how much more it's going to progress during the rest of their growing years. Lumbar curves, the number is 30 degrees. Over 30 degrees, curves typically continue to progress throughout the rest of their life. And usually it's 1 to 2 degrees per year. So that gives you an index for answering test questions. If you have a 50-degree curve, on the test they do not ask you gray zone questions on a surgery for a posterior spine fusion or idiopathic scoliosis. They will not ask you a 41-degree right thoracic scoliosis. They'll ask you a 50-degree curve or they'll ask you a 30-degree curve. They will not ask you a gray zone question. In my experience looking back multiple times, that's not happened. So if it's over 50 in the thoracic spine, they're going to want you to go to the surgery route. And I'll go over that in some more detail. So this allows you to, if you know that slide, allows you to categorize this, and that's basically all the questions on idiopathic scoliosis from an adolescent standpoint. If it's less than 20 degrees, we know the progression rate is small, so we're going to observe those patients. Between 25 and 40, or if they started at 18 and went up to 25, that's a brace category. They won't make you pick a Boston brace versus a Charleston brace, etc. They'll just say orthotic treatment or brace treatment, some form of the bracing therapy. And over 50 degrees is going to be a surgery category. It is that cut and dry on idiopathic scoliosis, adolescent idiopathic scoliosis on a test. One of the few things that is that cut and dry. And they don't make you measure it either. They always have it measured out for you. As far as the options for surgery are concerned, that's where it can get a little more controversial. Most cases, from a testing standpoint, posterior spine fusion with instrumentation is the answer. They haven't make you pick hooks, screws, wires, etc., or the brand, but they'll just say posterior fusion with instrumentation as your treatment, or anterior fusion with instrumentation. The anterior answer is predominantly for thoracolumbar curves, but even now that's becoming more controversial as people trend to do more things posteriorly now than they were anterior. So my guess is that they're going to probably fade away from the anterior instrumentation answers on the test questions. Anterior-posterior fusion is indicated currently for severe curves greater than 75 degrees and or curves of skeletal maturity, curves less than 10, kids less than 10 years old. The answer to the second one with skeletal immaturity is related to a phenomenon called crankshaft phenomenon, which I'll show you a slide of in a minute. If you have a posterior fusion which can't grow anymore and the anterior vertebra continues to grow, it will spin around the posterior fusion, creating a crankshaft phenomenon and worsening the deformity. So anterior fusion takes away the anterior growth and therefore eliminates the crankshaft phenomenon. The way they'll make you want to know that answer is they'll say you have a 9-year-old child with a 50-degree curve, or an 8-year-old child with a 50-degree curve, and they'll have on the answers posterior fusion or anterior posterior fusion. The answer to that would be anterior and posterior because of the crankshaft risk. And they will say it that way because if they put 80-degree curve, you probably would think automatically, oh, it needs anterior posterior for release purposes. They'll do that to trick you to make sure you understand that the crankshaft is the phenomenon on a kid less than 10 years of age. That's a visual depiction of what crankshaft phenomenon is. You have a posterior solid fusion mass and the anterior vertebra continues to grow, spinning around the posterior fusion. These are potential complications that you can have with idiopathic scoliosis. I've seen all of them on the test. Neurologic injury is pretty obvious, obviously. You're operating on the spine. Pseudoarthrosis typically presents itself as late pain. The two things that present as late pain typically are pseudoarthrosis and delayed infections. Pain over the implants, pain in the area where the fusion was, you have to think on a test, is this patient having an infection, or is it not fused, or is it not healed? Flat back syndrome is hopefully a thing in the past. With our segmental constructs, we're able to reconstitute the sagittal contour and pay as much attention to that as we are the coronal plane. But flat back syndrome came from having a distraction construct across the lumbar spine in particular, posteriorly, diminishing the lumbar lordosis. Crankshaft is what we just talked about. SMA, I put it that way intentionally because that's the way they've asked it on the test. Stands for superior mesenteric artery syndrome. Typically happens in thin kids that have a lot of correction. 60 or 70 degree curve that you get to take down to 10 or a small number. In a small child, that as you do that, you can create a superior mesenteric artery syndrome, which causes significant bowel problems. The treatment for it is initially is an NG tube because they get, basically it's an obstruction of their GI tract. So you do an NG tube to decompress their stomach and give them IV fluids and probably TPN to try to get them nutritionally balanced until they can get over their SMA. The causative organism for delayed infections now is more than 50% Propionibacter acnes. And that's been on the test a lot. That's why I put it on a separate slide. So if they have persistent pain, these two issues you need to think about. Is it a pseudoarthrosis? Other thing the pseudoarthrosis do that infection wouldn't is the deformity can progress. If it doesn't fuse, the deformity can continue to worsen. So worsening deformity in a child that has pain after a spine fusion, think pseudoarthrosis heavily. The infection issue is typically greater than a year. The delayed infection, by definition, is greater than a year or 9 to 10 months after the surgery with persistent pain, and they commonly have minimal symptoms, and their wound will look fine. You open up the incision and can culture it, and the majority of them are growing Propionibacter acnes. So that's the adolescent group. The infantile group, I intentionally have next because it has several characteristics which are in contrast. Number one being the child is young, obviously, less than 3 years of age. The category for infantile is 0 to 3 years. Juvenile is that 3 to 10 span, and adolescence above that. The biggest thing is their left thoracic curves. Remember, adolescents were right thoracic. Infantiles are left thoracic. Infantiles also, the males predominant, and adolescents, females predominant. The biggest thing you have to know from a measurement standpoint, they won't make you do it, but just so you know what it is the RVAD, and they usually write it like that. They'll say RVAD, and that stands for rib vertebral angle difference. Dr. Mehta described this years ago. I have a slide here demonstrating how you measure it if you're interested. They won't make you measure it on the test. They might show it to you, or they'll give you the number. They'll say the RVAD is this. The way you measure it is you draw your typical Cobb angle with a vertical coming up 90 degrees from it. Then you draw at this, and this is done at the apical vertebra. So in this curve, it would be right here. You draw your Cobb measurement with a vertical, and then you draw a line subtending the rib head on each side of that apical vertebra. So the difference between this angle and this angle is your rib vertebral angle difference. And so that's basically what it is. It's complicated if you look at the thing, but basically what it is, it's a measure of the rotation. If the child has a curve but without much rotation, then that rib vertebral angle will be about the same. The ribs will come off about the same angle on both sides. On the other hand, if there's a lot of rotation, the side that's rotated towards, the rib will come off at a steep angle, and on the other side, it'll come off at its normal neutral angle. So that'll be a bigger difference. So the kids that have a bigger rib vertebral angle difference have more rotation in their deformity. And the reason that's important is, in very particular and peculiar to infantile scoliosis, is if you have a mild curve, let's say a 30-degree curve, and a rib vertebral angle difference of less than 20 degrees, meaning there's not much rotation, virtually 90% of those curves will resolve and go away spontaneously, and probably they're positional in nature from inside the womb. So that's obviously crucial for treatment, as well as it's easily testable material, and that doesn't happen in any other kind of scoliosis. The second category is kids that have curves in that 25 to 35 degree range with a rib vertebral angle difference bigger than 20. They have a mild amount of rotation and a moderate curve severity. That's probably a curve that's going to get worse, or at least is worthy watching or treating. So those children are going to be treated either casting, where you manipulate and try to push that spine into a straighter position, or bracing. It's hard to brace a kid that's 2 years old or 2 months old because they outgrow it so fast. So commonly we'll cast them and then just continue to change the cast along the way. And the last category is the curves up and over 40 degrees with a rib vertebral angle over 20 degrees. Those kids need to have an MRI to make sure they don't have a dystrophic lesion, a cyst, a syrinx, a tether, a tumor, etc. and largely those kids will end up having surgery of some form. And I don't think it's testable at all to have you pick what kind of surgery in a 2-year-old anymore, because there's so many different options with the Vector, which I'll go over in a second, growing rods, and definitive fusion. It's too controversial. I think they might say that this child will need surgery or make you guide that you need to get an MRI to make sure there's not a dystrophic lesion. But you have to know that because of the size of the curve and the rib vertebral angle difference, that curve is at very high risk for progression. So there's basically 2 types of infantile scoliosis, the type that goes away and the type that's very bad. And there's not much in between. The last category of idiopathic scoliosis is juvenile onset, which is the gap, the 3-year-old to the 10-year-old. These kids have a very high rate of progression. If you thought about one of my initial slides on scoliosis was the risk for with skeletal maturity, the age of the patient, and amount of growth remaining. Well, if you're 4 and you have a scoliosis already, you have 10 years of growth remaining at least, so you're a very high risk for progression. At least 50% of these kids end up ultimately requiring surgery for treatment of their deformity. They also have a very high incidence of cord abnormalities, so spinal cord MRIs are warranted on these children, as high as 18 to 20% recorded in the literature of anomalies on MRIs. Most of them will require anterior posterior spine fusion if they're less than 10 because of the crankshaft phenomenon we talked about earlier. The treatment categories are all the same as they are for adolescent. Less than 20 is observation, 25 to 40 is bracing, and over 50 is surgery as far as testmanship is concerned. So that's the idiopathic variety. The congenital variety is the next phase. Congenital scoliosis implies either A, a failure of segmentation, which would be a bar or a bridge that didn't break down, didn't divide in the embryo, or a failure of formation, a hemivertebra, where only half a vertebra formed and the other half didn't, or some combination of both. The biggest thing to remember in congenital spine deformity from a starting standpoint with your evaluation is you have to rule out other associated anomalies. If you think about this, the spine is developing in about the 8-week-old embryo. Exactly the same time, the GU tract is developing, the cardiac tract is developing, the cardiac system is developing, and the neurologic tract is developing. So that's why you see those 3 systems listed as have a high percentage of a comorbidity or co-anomaly. So you need to first, in your mind, say, get an MRI, assess their GU system, get a cardiac evaluation to make sure they don't have the other anomalies as well. As far as treatment is concerned, the worst prognosis would be if you have failure of formation on one side and failure of segmentation on the other side. So in easier words, if you have a hemivertebra on the left side and a bar on the right side, that is virtually a 100% chance of progression. You have no potential for growth on the bar side and all potential on the hemivertebra side. That combination is lethal as far as progression is concerned. So there's a 100% incidence of progression in that instance. The treatment of congenital scoliosis, the only one that you say will do treatment on site is the one we just talked about. If you see a child with a 30-degree scoliosis, and they'll ask you this too because of the number, a 30-degree scoliosis with an ipsilateral failure of formation or failure of segmentation and a contralateral failure of formation, surgery is the immediate answer on that. It'll be anterior posterior in situ fusion. So that means front back, and because of the crankshaft phenomenon, you want to stop the growth. In situ means rather than trying to correct that deformity, you want to fuse it in situ so that it doesn't get worse, so it stays at 30 degrees and doesn't progress beyond that. That's the only one that you treat on site in congenital scoliosis. The rest of them, first thing you do is you rule out the associated anomalies like we talked about on the initial slide, the GU tract, cardiac, and the neurologic axis. Then the rest of them you treat for documented progression. And the documented part of that is the key. In congenital scoliosis, 10 degrees is considered documented progression. Because if you think about it, this curve is pretty easy to distinguish. But if you have multiple hemivertebras in a bar, it can be really hard to decide what you put your Cobb angle. So you have to have 10 degrees to call it documented progression. And from a test standpoint, they can make that very clear. Obviously, they'll say it went from 35 to 48 or something of that nature to show documented progression. The textbook answer is an anterior posterior spine fusion without instrumentation and in situ fusion. The reason for that is instrumentation throws added power, yes, and added correctability, yes, but it also has added risk. You have a congenitally anomalous spine with anomalous nerve roots, and the incidence of neurologic injury is higher as well. So from a test standpoint, the answer is anterior posterior fusion in situ, unless you have what this picture shows. an oblique takeoff at the lumbosacral junction. I think I've seen it 3 times in the last 5 years or 6 years on either the in-training or the board exam, where they've had an L5 level or an L4 level hemivertebra with an oblique takeoff in a child with a huge trunk shift leaning way out to the side, and the answer was hemivertebrectomy and posterior spinal and spinal fusion. Every other time it's anterior posterior in situ on the test. At the lumbosacral junction with the oblique takeoff, the answer will be hemivertebrectomy and posterior spinal fusion. So I put this slide on there just so that you would be aware of it, and remember, I can't imagine that they would ask you technical questions about the VEPTOR. VEPTOR stands for vertical expanding prosthetic titanium rib. So it's a titanium rib prosthesis. It was designed for kids that have fused ribs and congenital scoliosis. They get what we call a thoracic insufficiency. The ribs can't expand, so they can't grow, their lungs can't grow, and it leads to suffocation, basically, and they die at a young age because of their lack of thoracic lung development. I put it on there because it's been all over the JBJS for about the past 2 years. If you're not interested in pediatric orthopedics, you probably went and got another cup of coffee and turned a few pages and came back and read the next article or something of that nature. But it is going to be on there eventually to know what it is, and that's what it's for. You attach it, you do rib osteotomies, and you spread the ribs over time sequentially on an every 6-month basis or so to allow the lung to develop and grow. And it's actually a life-saving procedure for these kids if their lungs can grow. So it's probably going to come in the future. I don't think they're going to ask you here in the next 2 to 3 years. Certainly not on this year's test, I wouldn't think. So let's go to the other plane being kyphosis. Congenital kyphosis is similar to congenital scoliosis in that it's a failure of formation or a failure of segmentation, but it happens in the opposite plane. Rather than being in the AP plane, it's in the lateral plane. It is for sure the highest risk spinal deformity for neurologic injury or neurologic compromise. And I've seen them ask that question and list the other forms of deformity. Congenital kyphosis is the highest risk because the spinal cord is tethered over this apical deformity that's progressively worsening in nature. And it creates a prolongation of the spinal cord and creates problems from paraplegia from numbness and tingling on up to paraplegia. The treatment for this is either a posterior fusion alone, which would essentially be a convex hemiepiphysiodesis, meaning you're trying to stop the growth on the convex side of the deformity and allow what growth there is on the anterior side to continue to grow. Or a more definitive answer would be an anterior-posterior fusion, where you just say we're going to fuse it anteriorly in the front and the back, take away all the growth, and then accept that that deformity is going to stay in that position but not get worse. And in situ without instrumentation is for sure the answer on the test question because the risk of neurologic compromise is so high in this deformity. So let's talk about spine deformity as it relates to neurofibromatosis. I'll talk about neurofibromatosis several times a day because it's on the test a lot, it's very testable, and it's something you should readily recognize. It's autosomal dominant. The spine is for sure the most common site of skeletal involvement of neurofibromatosis. This child has verrucous hyperplasia, hemihypertrophy, cafe au lait spots, all the typical stigmata of neurofibromatosis. But from a spine standpoint, these are the code words you'll see. They won't tell you this child has neurofibromatosis. They'll either show you an x-ray like this, where you see a short segmented, sharply angulated curve with penciled ribs across the apex, as I'm pointing to. And you can see here on the more blown up image. And in kyphoscoliosis, they get scalloping of the vertebra like this from the neurofibromas. And it's a dysplastic form of scoliosis. So they get vertebral scallop, or they might just give you a paragraph and not show you the picture. A child with a 60-degree scoliosis over 5 segments of the spine with scalloping of the vertebra, enlarged foramina and penciling of the ribs. That's neurofibromatosis just from that description. Until proven otherwise, that's neurofibromatosis. And the reason that's important is the treatment for neurofibromatosis scoliosis is dramatically different. 100% of the time you have to do an anterior-posterior fusion, just like in spina bifida. And the reason for that is the pseudoarthrosis rate with a posterior fusion alone is as high as 35 or 40%. With anterior and posterior fusion, you can drop that rate to something in the neighborhood of 10%, which is still annoyingly high, but not as high as doing posterior fusion only. Bracing is ineffective because it's a dysplastic congenital type scoliosis. It's not an idiopathic scoliosis. So you can't brace these kids. And most assuredly, you need to get an MRI preoperatively because these kids will get what we call dumbbell lesions, where there'll be nerve root coming out with a neurofibroma on one side of the bony canal of the neuroforamen and another one on the other side. In between where the foramen is, it's neutral, so that makes like a dumbbell. So if you go in there and straighten that spine, you're going to put a lot of traction across that nerve root, and you can actually take it out. You can avulse the nerve root. So you need to do an MRI preoperatively to make sure you know where the dumbbell lesions are, so you can decompress them if you need to, or that you can compromise your correction plans accordingly. I'll come back to neurofibromatosis again in the lower extremity talk as well as the syndrome talk, because there's lots of questions in there. Spondylolysis. I put on there that word. I don't know if you know what that word is or not, or if you've seen it before. I'm sure you've seen it by now, where you are in your training at this point. But spondylo means spine, and lysis means fracture or crack. It's some form similar to a stress fracture, a repetitive overuse type problem. Most commonly in a gymnast in the young ladies. In guys, it's a weightlifter or an offensive lineman that goes from a flex to an extended position over and over and over again. It's repetitive hyperextension that causes the problem. They almost always come to see you for low back pain. That's the main predominant pain, and usually they can point right to their lower lumbar spine as the main source of their difficulty. And it's very much activity related. This does not happen in couch potatoes. This is an athletic type person typically. If you're really lucky, you get an x-ray and you see a cleft like this in the L5 region, but I find that to be less than 50% of the time. Most of the time they'll come in, I'll get an x-ray, which like I always do. I get AP lateral and obliques to see if I can see the pars fracture in the Scotty dog neck region of the pars interarticularis. Most of the time it'll either be fuzzy or not completely definitive. If I'm convinced that they have significant back pain that's not mechanically related, which is a different category, and on the test they'll say they have persistent back pain with a normal x-ray. The next test is either a bone scan, which I do in the form of a SPECT scan, as you see here, or a CAT scan. From my perspective, the advantage of the SPECT scan is it helps me localize where I want to get my CAT scan if I need to. And if you see a hot spot on the SPECT scan, you know where to go. The downside on the SPECT scan is some of these are cold. And if it's cold, then you have another test that was negative, and if you're still convinced, then you get a CAT scan. So my usual regimen is I get a plain film if that's negative, and I'm convinced there's a problem. I'll get a bone scan, that's the next step. If that's negative, maybe it's a cold spondylolysis, then I'll get a CAT scan. And they have made you go through that algorithm on the test, and that's actually been in the literature recently. So this is what a spondylolysis looks like. It's out of plane when the facet joint in this region would be in this plane, and also it's more irregular than the facet joint would be. But one or two cuts above this will be the joint, so it's easy to miss. The treatment for this, almost always, I start off conservatively. By conservative treatment, I mean, number one, just like you would if a pitcher has a sore shoulder or a sore elbow, you say, let's rest it for a while and see if it gets better. They do not usually heal with direct bone union, but commonly they'll get a fibrous union and it's not as symptomatic and doesn't bother them, and they can gradually get back to their activities. If that's the case, then I gradually let them go back to their activities and move on. If they're chronic, meaning more than 9 to 12, on the test, if they're greater than 9 to 12 months out, it'll be obvious on the test if they want you to operate on it. They'll say this child has failed conservative management, or he's been in a brace for 9 months, and despite that he still has back pain. That's the child that you do the repair on. That being said, that's an exceedingly rare test question. I think I've seen it once in maybe 10 years on the test, so it's not a very common issue. But what you want to do when you treat it is try to repair the spondylolysis. The reason you see I have this x-ray on here is this wire goes around the transverse process and then back to the spinous process. That allows me to compress across the Scotty dog neck region, which is the pars interarticularis, to allow for some compression, much like you would put a compression screw. And in fact, commonly I'll use screws. Nowadays, I'll put a cannulated screw out across the pars interarticularis if I'm going to treat surgically to try to afford some compression. Spondylolisthesis. Spondylo, once again, is spine. Listhesis obviously implies slippage. The main versions in children that we see are dysplastic, meaning a congenitally elongated pars interarticularis, and isthmic, which would be if they had a spondylolysis and then developed on, versus tumor. Tumor being the most rare. We obviously don't see the degenerative variety much in children. The biggest difference between those three is in the dysplastic child, the pars is intact. And so that means that there's a continuum of bone along the whole axis around that dural tube. So at least when you have a pars defect, the posterior fragments being loose provides for some decompression. If they have a spondylolisthesis with a congenital or dysplastic type, almost always those children are very symptomatic because that pulls the dural tube anterior with the L5 vertebra, and they commonly can get a cauda-equina syndrome or more significant neurologic issues. The surgical indications from a testing standpoint are very straightforward. A grade 3 or higher on presentation, and the grades are done based on the percent slippage. So you divide the sacrum into 4 sections. 0 would be no slip, 1 would be 25%, 2, 50%, 3, 75%, 4, 100%, and 5 is all the way off, or spondyloptosis. So this would be about a grade 2 slip. So 50% or greater is a grade 3. That's an automatic indication for surgery. Progression of the deformity was a grade 1, went to a grade 2, was a grade 0, went to a grade 2. Grade 1 went to grade 3. That is an indication for surgery. Or failure of non-operative management, which is the little bit soft version. I haven't seen them ask you that much on the failure of non-operative management unless they say, child has a grade 2 spondylolisthesis, has intractable back pain, has tried conservative treatment unsuccessfully. Otherwise, they want you to know that it needs to be grade 3 or higher or progression from a testing standpoint. The treatment surgically, most of the time we can do this from an all posterior approach, although usually we do some anterior work, as you can see with the cages, either by PLIF or TLIF, take out the disc and pull it back. But typically, for grades 1 and 2, we do an in situ fusion because the slip's not that bad. For the higher grades, a grade 3 or grade 4, the answer is to try to improve the slip angle. So take them out of that extremely forward flexed position at the lumbosacral junction, the lumbosacral kyphosis. You want to improve that by improving the slip angle with instrumentation and fusion. Sherman's kyphosis is a specific type of kyphosis. They'll show you an x-ray such as you see on the right, where you have end plate irregularities, Schmorl's nodes, and apical wedging greater than 5 degrees across 3 consecutive vertebrae. That, by definition, is Sherman's kyphosis. The treatment for Sherman's kyphosis, mainly conservative. If the kyphosis in the thoracic spine is less than 65 degrees, normal range for kyphosis in the thoracic spine is up to 40 degrees. So if it's 60, 65 or less, observation is the treatment across the board. Between 65 and 80 degrees, from a test standpoint, you need to use a brace. The reason I put CTLSO on there is because that's the brace you need to use if you're going to treat thoracic kyphosis. It does no good to do an underarm brace, just a TLSO for thoracic kyphosis. It stops at about T7, which is the apex of this deformity. So you have to use a cervical thoracic kyphosis, a cervical thoracic lumbosacral orthosis to treat this. Another word for that would be a Milwaukee brace, the brace that comes up around the neck. Obviously very difficult to get compliance, but on a test they can ask you that for sure. Surgical treatment on the test for Sherman's kyphosis, curves greater than 80 degrees. Landmark article about 8 years ago describing anterior-posterior fusion as the definitive answer for Sherman's kyphosis greater than 80 degrees. There's been a few reports over the last 3 years stating that with posterior instrumentation with screws and osteotomies, you can do posteriorly based only instrumentation and not have to do the anterior-posterior approach. So that's one major advance that the pedicle screws have allowed us to do in the treatment of this deformity. Klippel-Feil syndrome, you need to know what it is because they'll assume that you know what that is when they say that on the test. Essentially what it is abnormal cervical segmentation. The actual syndrome itself was described in the pre-X-ray era. So the classic triad is a low hairline, as you can see here, a webbed neck or a shortened webbed neck, and that's because they have abnormal cervical vertebrae, and limited cervical range of motion because they have abnormal cervical vertebrae. So notice that in the classic triad, there's no X-ray available in that triad, and that's been on the test, which I thought was a little bit of a weak question, but that's what they like to do. The treatment for this is mainly conservative. You can't do anything to create a normal vertebra. If they have progression of the deformity or instability, you treat the instability, but by and large, they do not. Atlantoaxial instability, C1, C2 instability, common in Down syndrome. In the pediatric population, that would be the #1 category in children with Down syndrome, juvenile rheumatoid arthritis, and the osteochondral dystrophies, the mucopolysaccharidoses, and I'll go about those in the syndrome talk as well. The main way they'll ask you that, they won't just say the child has cervical spine instability. They'll say, for example, in Downs, they'll say this child is normal active and now has a more broad-based gait, because Down's children don't commonly complain of pain. They might come in holding their neck or their head, but they won't verbally tell you my neck hurts or that it hurts when I move my neck. And so you have to be pretty cautious about the way you look at the test question. Loss of motor milestones, dysfunctional bladder problems, or gait abnormalities are typical ways that they'll present. And the other way they'll do that to you is on a preoperative evaluation on a child with Down syndrome or rheumatoid arthritis or Hurler's syndrome or mucopolysaccharidosis. They'll say, what do you need to do for the rest of your workup if you're going to do a lower extremity osteotomy, for example? You need to get flexion, extension, cervical spine radiographs to clear them for anesthesia. So you have to remember in your mind that those kids are more prone to having C1-2 instability. The flexion extension x-ray is the way you diagnose it. The treatment is according to the amount of instability. If they have greater than 7 millimeters, 7.5 millimeters of instability, then a cervical spine posterior fusion is the answer from the testing standpoint. C1, C2 instability from a rotatory standpoint, they typically present with a sort of cock-robin appearance or a little bit of a mild torticollis. Grizzle's disease is caused by retropharyngeal irritation. The reason I put that on there is the one presentation that I've seen asked is a child had an upper respiratory infection, was playing in a soccer game, was heading a soccer ball, and suddenly had some irritability in the neck and had a picture of him like this on the test. So what happens is we think the lymphatic drainage from the upper respiratory tract is parallel or in parallel with the cervical spine lymphatics, and you get a little bit of edema in that area, and it makes it a little more prone to a rotatory type subluxation at the C1-2 joint. Commonly, you have to get a CT scan for diagnosis. If I see these kids acutely, like this guy, I put them in traction. And that's the answer on the test for sure, to start off with traction, cervical traction, and it doesn't have to be a large amount, just 5 pounds of cervical traction, to see if you can relax that joint and allow it to come back into its normal position. In cases that are chronic or in cases that are resistant to the traction, sometimes we have to do a posterior fusion, C1, C2. Here's what you see on the CT scan. You see that C2 is rotated out of plane from C1. And that's common. I've seen on the test where they show you a picture of the child I just showed you and this CT scan. And you have to recognize that's a C1-2 rotatory subluxation. The next thing you need to know, this one you need to know from your practice standpoint as well as on the test, and that's pseudo-subluxation. In kids that are less than 8, in their cervical spine, their facets are oriented much more horizontally than they are in adults, where the cervical spine facets become more vertical as the neck gets longer. The way you diagnose, and this is an example, at C2, posterior vertebral line, and C3. This is an asymptomatic child in the emergency room, thought to have subluxation C2 on C3 and potential cervical spine instability. So how do you rule that out and go down with definitiveness, where the downside is if you miss it, it's a big problem, and say this is pseudo-subluxation? Well, Swiss-Chuck's line is the way you do that. You put a dot at this is the spinal laminar line, where the two lamina meet on the lateral x-ray will make a more increased radiodensity. At C1 you put a dot, at C2 you put a dot, and at C3. You draw a line between C1, the spinal laminar line at C1 and C3, like this. And if it intersects or comes within 2 millimeters of the C2, the spinal laminar line, it is pseudo-subluxation, because the vertebra won't go forward at the vertebral level and not have the lamina come with it. So that would be pseudo-subluxation, and that's very important to know in your clinical practice as well as on the test. Torticollis. This child is a lot younger than the kid I showed you before that was a soccer player with upper respiratory infection. This child is a toddler. CMT stands for congenital muscular torticollis, and I have seen them use these abbreviations, so I put the abbreviations intentionally in your handout because that's commonly how they ask it. If there's a palpable mass in the sternocleidomastoid muscle and they have a head tilt, by definition that's congenital muscular torticollis. It's commonly associated with plagiocephaly. What I mean by that is the head has some asymmetry. Look at this child closely. The cheek on this side is a little more robust than that side. He has way more hair than me, so you can't see about the rest of his scalp. But commonly their head will be a little bit asymmetric as well. And so that's something that's commonly associated with torticollis. They also have a much higher incidence of developmental hip dysplasia or hip dislocations, about 10 to 15% higher chance than they would in kids without torticollis. If there's no palpable mass, if you see a child with this torticollis and you can't feel a mass in their neck, or someone else didn't feel a mass in their neck, you better get x-rays to make sure it's not Klippel-Feil or some other form of congenital bone structural anomaly of the cervical spine. Hip and knee is next. So obviously it makes sense to me to start off the hip and knee talk with a congenital dislocation of the hip. It's the most commonly asked. One of the most common things we see as a pediatric orthopedic surgeon. Probably one of the few things I think it's legit the way they ask you the questions, because I hope I never miss a CDH, and I hope you guys don't either. The risk factors for congenital hip dislocation: firstborn child, female, breech presentation, and positive family history. Those are the big four. I ask that every time I see a child that comes in, a newborn child that I see. And those are the big four factors. If any one of those factors is positive, automatically your antenna should go up to make sure you're not missing that. It's associated with other what we call packaging deformities. One we just talked about, torticollis, where the head's crunched against the inside of the womb, and the packaging deformities can create a hip dislocation as well. It's also metatarsus adductus, where the feet are cramped in the position in the womb as well. This is a typical x-ray. At first glance, it's not alarmingly abnormal, but you can see that the capital epiphysis is smaller on the affected side than it is on the unaffected side. The femoral head is not deeply seated within the acetabulum as it is on the right side. And these are subtle things you can see on a child. You can't usually see the ossific nucleus until the child's 6 months of age, but after that age you can see that very readily. The way you need to know from a testing standpoint as well as clinical exam, in addition, the two big signs, Ortolani sign and Barlow sign. Ortolani is a reduction maneuver. You come up to the hip and it's dislocated, and with your finger, your index finger on the greater trochanter, you relocate that hip. That's an Ortolani positive sign, Ortolani sign. Barlow sign, you come up to the hip and it's in the socket, like the picture on the bottom. And you can see the added pressure applied by the thumb, trying to see if that hip is unstable enough to allow it to be pushed out or subluxated out of the joint. So Barlow is a dislocatable sign or a provocative sign. Another clinical sign you'll see is an Alice sign or a Galeazzi's test. That implies limb length discrepancy. That's why I took this picture. This leg looks like it has shortening, but really what it is that hip's posteriorly dislocated. When you bring the knees up to hip flexion at 90 degrees, there's an apparent limb length discrepancy. And that's created from the hip being dislocated posteriorly. Usually the adduction contractures and the limb signs develop later on, 4 to 6 months after the hip's been dislocated. On a child who's Barlow positive, the hip's in the socket, so they won't have a limb length discrepancy unless you examine it when the hip's dislocated. X-ray signs. We love to draw our little lines across on x-rays. They'll always have the lines drawn. You just have to know what they are. So H is horizontal, and horizontal is Hilgenreiner's. That's this line. Goes through the you put a dot on each triradiate cartilage and draw a line between them. That's Hilgenreiner's line. The perpendicular line to that is Perkins, perpendicular in P. And so that's at the lateral margin of the acetabulum, vertically drawn because it's perpendicular to Hilgenreiner's. So you draw those two lines, and the rest of them are cupcake. That divides the hip into 4 categories. The acetabular index goes from your dot from the Hilgenreiner's line up to the Perkins line. That's in that angle right there is the acetabular index. You use that quadrant to decide if the hip's dislocated. The normal position for the medial aspect of the femoral metaphysis is in the inner lower quadrant of the hip joint. So clearly you can see this one's in the lower outer quadrant. A high riding dislocation would be in the upper outer quadrant. A reduced hip is in the inner lower quadrant, the metaphysis. And the reason the metaphysis is key because commonly these kids have very delayed or absent ossification in the capital femoral epiphysis, so you can't see the femoral head. It'll just be a blob of gray cartilage. So you have to see the metaphysis and know that it's lateral to the Perkins line, and that therefore is a dislocated hip. The treatment of a congenital dislocated hip is very much not controversial as far as an infant is concerned. If it's a non-teratologic, reducible hip, Pavlik harness or some form of abduction brace is the treatment of choice. The reason I put Pavlik harness on here and also a picture of the Pavlik harness is because that's the most commonly tested by far and away. The treatment of Pavlik harness is acceptable up to 6 months of age. And adjustment factors that you need to know on the pelvic harness are the anterior straps, which are these right here. They go from the leg portion up to the chest. Those control hip flexion. The posterior straps control abduction. That's these straps on the outside. So if you tighten those, it pulls the hips into abduction. So anteriors for flexion, posteriors for abduction. That's critical because you don't want to have them in extreme abduction or extreme flexion, because that can increase the pressure on the femoral head, increase your chances of complications such as avascular necrosis or femoral nerve palsy. You can get a femoral nerve palsy, which on a test seems unreasonable as an answer. But if you have a little pudged child like this that has their hips way flexed, and that crease there, and they're in that position for 2 to 3 months, you can pinch the femoral nerve adequately enough to create a femoral nerve palsy without question. The next category up would be the irreducible hip, because as I said before, pelvic harness is contraindicated if the hip's not reducible. So if you have an irreducible hip or a child that's over 6 months of age, the next category of treatment options goes into arthrogram and or closed reduction. You do an arthrogram to see what the dynamic stability of the hip is, as well as to document if there are any obstacles to reduction of the hip. They commonly will show you this picture, obviously without the words, and have you describe what's the arrow pointing to. Anything within the joint is going to be a filling defect. And so at the inferior margin of the joint and extending up to the femoral head will be the filling defect for the hypertrophic transverse ligament or the ligamentum teres coming up from the base of the joint up to the femoral head. The inverted limbus will also be a filling defect at the superior margin of the acetabulum. So the purpose of the arthrogram is to demonstrate whether or not that hip is reducible and whether or not it's stable enough to proceed onward with a reduction. If it is, then the treatment in that age group is a closed reduction, meaning manually putting the hip in the socket, and spica casting. The next phase after that is if they present after walking age, meaning at 12 months, 18 months, 2 years of age. In that category, from a test standpoint, the treatment is, because they'll usually say the kid's a year of age has an irreducible hip or unstable hip, and what's the option for treatment? That's when we get into the open reduction. And the reason we do an open reduction is so that we can get the hip manually back in the socket, plus or minus whether you do a femoral osteotomy. The reason to do a femoral osteotomy is if, when you put the hip in the socket, if it's too tight, the hip's been dislocated up and out of the socket for a while, and you bring it down into the socket. If it's too tight, which is very much a clinical decision, then you do a femoral shortening osteotomy to try to diminish the pressure and decrease the chances of avascular necrosis. The femoral osteotomy is commonly, and most commonly, sufficient and enough to get you through until they're about 4 years of age. If they present at 4 years of age or older, then you have to do sort of the full court press, open reduction, capsulorrhaphy, femoral osteotomy, and usually pelvic osteotomy. So 4 years and older, you have to do all of those. The in-between category, the toddler or the walking age, we do typically a femoral osteotomy and open reduction. The real questions are, when should you put hips back in? At what age group should you stop? If it's over age 6 and it's bilateral, from a testing standpoint, probably should be left out. If it's unilateral and they're over age 8, they should be left out. And that's because age 5 and 6 and up to 7 is when the majority of the acetabular development happens. So by that age, if they're up to that age, the acetabulum is already pretty well established and not really going to conform much to it. So the outcomes of children over those age groups is so questionable that probably they're best left alone. And from a testing standpoint, it can be cut and dry. In reality, that's a little bit more of a gray zone. Hip dysplasia, as opposed to dislocation, is a little bit more soft in its description. You notice I have my lines drawn back on this x-ray. There's the Hilgenreiner's line, there's Perkins' line. And then I have 2 numbers written up here. That's the acetabular index. Remember I told you before, you start at the trivedic cartilage and draw the line up to the Perkins line? That angle is the acetabular index. Normal acetabular index is less than 30. So 46 is obviously markedly abnormal. And that would qualify as hip dysplasia or acetabular dysplasia in particular, in contradistinction to hip dislocation. It's probably a continuum of diagnosis, but this is prevalent just I mean, this is important just to be called acetabular dysplasia because the treatment's different. This implies that the hip is located. Remember earlier I said that the capital femoral epiphysis is commonly gone, and you need to make sure that you know where the medial metaphysis of the proximal femur is. Here it is here, and here it is here. So it's within the medial quadrant, the inner lower quadrant of the hip. So it's not a hip dislocation, but there's definitely acetabular dysplasia on board. The treatment for acetabular dysplasia in the 3-month-old, such as this child, is some form of abduction splinting. You can do a Pavlik harness, you can do a more rigid brace such as a rhino brace. They typically ask you just the code word of abduction bracing. They don't make you pick between different types of abduction bracing for this particular problem. Adolescent hip dysplasia is probably a residual of hip dysplasia as an infant that as time went by, the acetabulum did not completely develop. The treatment is two opposite ends. There's no bracing that's effective because the cat is out of the barn, so to speak. The growth plates have closed. So you either have conservative options versus surgical options. As time goes by and people are becoming more aggressive with joint preservation techniques, osteotomies are becoming more prevalent. The options you have are femoral osteotomy if you have a child that has a lot of excessive valgus in the proximal femur, or pelvic osteotomies. Pelvic osteotomies predominate the treatment. The reason I've mentioned these 4 particular types is because there are things that are similar and very testable and commonly being tested. The Salter and the triple or the steel innominate osteotomies are fairly similar. The Salter hinges off the symphysis pubis and is cut through the greater sciatic notch up to the anterior iliac spine. The triple has that same cut, but in addition, it's called a triple because you cut the superior and inferior rami anteriorly, the ischium and the pubis, and therefore you can rotate the acetabular fragment more freely. So instead of hinging on the major difference between the steel and the Salter is that this one, the Salter hinges off the symphysis pubis, and the steel hinges off the 2 cuts on the ramus of the ischium and the pubis. The PAO, or the GONS, or the periacetabular osteotomy, is the nuance to that is that it leaves the posterior column intact, which leaves a very testable question. Which of the below pelvic osteotomies are more intrinsically stable? Which of them allow more rapid weight bearing because the posterior column's intact? And it's closer to the joint, so you can gain more correction in that regard. And the last of them are what I would call or classify as salvage type procedures. The shelf procedure, where you put a wedge of bone over the lateral aspect of the acetabulum and allow it to fill in, or the Chiari, where you push the ilium, cut the ilium and translate it laterally for improved coverage. Those require metaplastic change within the capsule of the hip joint to form fiber cartilage. So it's more of a salvage type procedure, and you need to know that as far as categorization of pelvic fractures is concerned. Congenital coxavera is a visual diagnosis. These children typically have a bit of a waddling gait pattern because of their coxavera, but you need to know that you need to just be able to recognize that x-ray and recognize that neck shaft angle is at 90 degrees where it's supposed to be 135, and they get an inverted Y growth plate that you can see on both sides in this particular image. I haven't seen it asked commonly, but when it is asked, if you recognize it, the treatment is very straightforward and makes for an easy test question. The bottom line is if the neck shaft angle drips below 90 degrees, the answer is a valgus-producing osteotomy to try to reconstruct or restore a more normal neck shaft angle. Perthes disease is exceedingly controversial as far as the treatment is concerned, but very testable as far as recognition. At first glance, that x-ray doesn't look terribly unusual, but as you scour it a little more closely, you can see the epiphyseal height of this side is more than double the height of this side, more radiodense on the affected side than it is on the non side, and that's avascular necrosis of the capital femoral epiphysis. Almost always presents with pain. Can be thigh pain, can be knee pain, can be hip pain, and they can try to trick you on the tests on those extensively. The boys are affected 3 to 4 times more than the girls. Ages 4 to 8 are the most common, and bilaterality is about 12 to 15%. The biggest thing you need to know from a prognostic standpoint is that the younger you have this, the better your results will be. And that makes sense if you think about it, not only just because younger kids heal better, but also the acetabular development happens, as we were just talking about in acetabular dysplasia. The majority of that acetabular development happens before age 6. So if your onset is less than 6, the acetabulum can contour itself and reconstruct itself via growth to accommodate whatever deformity you have as a residual of your Perthes disease. So less than 6 is a big cutoff. But ultimately, the outcome is determined by having a round head. The more round your head is and the more spherical your head is, the better it fits into the acetabulum, the less likely you are to have downside effects. As far as treatment is concerned, largely it's supported. Less than 6 years of age, almost across the board, you would get universal agreement that we should leave those kids alone because they do so universally well. The category where it becomes difficult is the older child, as you see in this picture, where they're 8 years or older. There's much more enthusiasm coming on board now for femoral osteotomies and or pelvic osteotomies to try to improve the coverage of that femoral head. As the avascular necrosis takes hold, you get coxa magna and coxa breva, and the head becomes too large to fit into the socket. So some form of containment where you put the femoral head via varus osteotomy in the proximal femur more deeply into the acetabulum, or an acetabular osteotomy to improve your coverage, has become more in vogue. The literature is not completely out as to whether or not long-term that's more beneficial in the observation group, but there certainly is lots of argument in that area. Slip capital femoral epiphysis is something that's very commonly tested and easily testable. More common in kids that are overweight. It occurs during the time they have their rapid growth, and it's more common in males. The biggest thing you need to know anatomically and structurally is this fracture occurs, or slip occurs, through the hypertrophic zone of the physis. The cartilage is enlarged there, and that allows for it to slip. And the neck displaces posteriorly, as you can see in this CT scan, which I have intentionally in that position. So you can see that it slips posteriorly. The reason that's important is when you're trying to fix these children, if you put a screw like you would conventionally for a femoral neck fracture up the neck, you will airball that epiphysis. So you need to go perpendicular to the growth plate. So your screw almost always needs to start somewhere on the anterior surface of the neck for fixation, and that's important to know both in treating these as well as on your test. And other things you need to know is you need to be able to diagnose on subtle x-rays. This is a common x-ray that I've seen them show you on the in-training as well as on the board exam, where at first glance that doesn't look too bad. You have to look and see. You draw a Klein's line on the lateral border of the femur, and there's no intersection of epiphysis. There should be some epiphysis that the lateral Klein's line touches. It touches some on the other side, but none on this side. A little bit of widening of this physis compared to that physis. Yes, I know that's subtle, but that's the kind of things they ask you on the tests. And if you see the frog x-ray, it's a little more easily depicted. You can see that there is definitely some slippage posteriorly of this capital epiphysis and definite widening of the growth plate. The categorization as far as slips are concerned is quite straightforward and easily readable and testable. Stable and unstable. A stable slip walks into your office or walks into the clinic or walks into the emergency room. Unstable slip is unable to ambulate. Very strict black and white criteria. The treatment for those two, both of them, is to pin the epiphysis. Majority of the time, there will be a pin in situ. On a test, I would say it would be 100% of the time. The answer would be in situ pinning for slip capital femoral epiphysis. With the advent of cannulated screws, this becomes a much more straightforward procedure that you can do through fairly small incisions. Other things you need to know on the test, that if the child is less than 10 years of age, by definition, you should get an endocrine workup to make sure there's not some type of endocrine pathology underlying this that could create hypertrophy of that hypertrophic zone of the physis and make them more predictable for slip. If they're less than 10 and they have endocrine pathology, you should pin both hips. Bilateral pinning, even the asymptomatic other side if the child's less than 10. This is an example of that same child I showed you previously with the pin in situ. The less severe the slip, technically, the harder the pinning, in my opinion, because your starting point gets more along that anterior lateral ridge of the proximal femur, and you can skive off the proximal part of the femur, which can make it more difficult to pin. Proximal femoral deficiency. In this pathology, you'll see a child such as this picture on the right where they have marked shortening, and I've seen this exact picture or very similar on the test. This child happens to have bilateral proximal femoral deficiency, just worse on one side than the other. But they have a very short thigh. Commonly, they have a normal foot. The foot will look extremely normal, and they can either have a totally absent hip or a pseudoarthrosis at the top of the hip. The major problem, the major issue that's coming up from a testing standpoint is this sonic hedgehog gene. I'll go over that in a little more detail in the section that we have on syndromes after the break. Sonic hedgehog gene in about the 8-week-old embryo codes the embryo to develop limb buds. And so it's a big gene focus now, and lots of research is going on in that in longitudinal deficiencies. Proximal femoral deficiency definitely can be created if you have deficiency in the sonic hedgehog gene. It's a spectrum. It can be anything from a femur that's just a little bit too short, called a congenital short femur, all the way down to no femur at all, such as you saw as that child on the previous slide, or just distal anywhere in between. The treatment options depend on the magnitude of the deficiency and the function. It can be anything from an amputation to nothing at all, to lengthening, to epiphysiodesis. And the word I put in there that you'll need explanation is Van Ness rotationplasty, which is shown here. You turn through the knee typically, or through the femur itself, turn it 180 degrees. So then what was formerly ankle dorsiflexion becomes knee flexion. The good part about that is it allows them to function as more of an above knee, or excuse me, a below knee type prosthesis as opposed to an above knee type prosthesis. This is an example of a child with bilateral proximal femoral deficiency. I would say nearly 100% of the time children with bilateral proximal femoral deficiency do not have any surgery because they're not perfectly symmetric, but at least they're relatively symmetric. If they have unilateral involvement, your options are you can use an unconventional prosthesis such as this, where you just basically accommodate that plantar flexed foot and give him a lift that goes from the floor up to his foot. Or you can do a rotationplasty such as this and allow him to function in a more below knee type brace. If they have a cervical pseudoarthrosis, which is common in the children that have a proximal femur in this disorder, you repair that by creating, and therefore hopefully restoring the hip socket and retaining some abductor function. Or they can just have a congenital short femur, where the femur's there, all the parts are there, it's shorter. These children with the congenital short femur just present with a typically externally rotated leg and slight coxavera and a little bit shortening in the limb, a little bit shortening meaning somewhere on the 2-inch or less realm. The biggest thing you need to remember from a remainder of the limb standpoint is almost always they're absent in their ACL. And this is crucial not from an instability standpoint, because usually they're not terribly unstable. But if you do a lengthening through a knee without an ACL, you can get joint subluxation issues, which can be a big problem. As far as the discrepancy is concerned, use the Moseley graph. They usually ask one question a year on the Moseley graph. The rule of thumb applies just as well as the Moseley graph, in my opinion. Rule of thumb being the distal femur grows 9 millimeters a year, the proximal tibia grows 6 millimeters a year. Boys grow till they're 16 on a test. Girls grow till they're 14 on a test. And you can span it out and figure out when on the test, either that way, or you can confirm your answer based on that versus the Moseley graph. In general, treatment of the limb length discrepancy, if it's less than an inch and they're asymptomatic, no treatment at all necessary. If they do have some symptoms and are less than an inch, a shoe lift is probably the most prescribed and the most commonly answered as far as on the test is concerned. There's no evidence in the literature that less than an inch will cause any long-term issues with lower back issues, and that's the reason for that test question. The next level up would be an inch or 2.5 centimeters up to 4 centimeters. From a testing standpoint, epiphysiodesis is something I would suggest you consider on the test if they still have open growth plates, obviously. Over 4 centimeters is in a lengthening category because that's getting up in the close to 2-inch range and a little bit too much for an epiphysiodesis to accomplish. In reality, lots of times if kids get 4 and 5 centimeter discrepancies in these large longitudinal deficiency syndromes, we'll do both. Do an epiphysiodesis on the long leg and then make up the difference with the lengthening on the short side. Amputations, the biggest thing you need to remember about amputations, number one, preserve as much length as you can. And most importantly, try to make the amputation go, if you can, through a joint. Because overgrowth is a big issue. And children that have overgrowth, it becomes a continual problem that you end up having anniversary surgeries every year or two to go in and trim down the overgrowth so that they can get their prosthesis to work again. In general, they'll want you to know when you fit for amputees for prostheses. Extremely functionally based and developmentally based. Most kids start sitting independently about 6 months. That's when they start to use their hands in an upright position. So that's when you fit an upper extremity prosthesis, typically at 6 months, and usually you start with a passive mitt. In the lower extremity, most kids start walking at about a year of age. So at about a year of age, that's when they're usually fitted for their lower extremity prosthesis as well. So it's completely based on their developmental issues. I put this slide on there like many others because it's a recognition problem that obviously that knee's going the wrong way. Congenital dislocation of the knee is something that's not terribly common, but it is alarmingly noticeable. It's frequently associated with congenital dislocation of the hip on the same side. So you'll have an ipsilateral hip and knee dislocation, so you don't want to miss that. And when treating this, you need to treat the dislocation of the knee first. If you think about it conceptually, it makes some sense if you think about that. The treatment for the congenital hip dislocation is going to be a Paediatric harness, right? So there's no way you could get that child in a Paediatric harness because you have to have the knees and the hips flexed at 90 degrees to go in the Paediatric harness. And so you have to fix the knee dislocation first and then deal with the hip dislocation. The way you treat the knee dislocation, at least 90% of the time we're able to spontaneously get those to reduce with manual manipulation and casting, long leg casting, done on a weekly basis until we're able to get the knee into a 90-degree flex position. Congenital patellar dislocation is something that can be missed in a child like this. The smiley face is on the kneecap or on the patella. It's easy to miss in a child at the walking age if they're a little bit heftier than normal. It can be a little more noticeable as the child gets older, but there's several varieties of these. This would be a congenital dislocation, which is 100% dislocated. In the middle is more of an obligatory type. What I mean by obligatory is that every time the knee goes into flexion, that patellar dislocation reduces in extension. Flexion and reduces in extension. Two different varieties of congenital dislocation of the patella. The treatment for congenital patella dislocation is largely surgical. You have to release the lateral retinacular structures to allow you to pull the knee back into a better position, but it won't just stay there. You always have to add some type of support, and most commonly we use the semitendinosus tendon that we drill a tunnel through the patella and then pull it back upon itself, as you see in this diagram. Originally described by Galeazzi as semitendinosus tenodesis. So we take the tendon from the semitendinosus, pull it through the patella, and that allows us to have a check rein ligament, if you will, to pull that patella more medial to hopefully prevent it from resubluxating laterally. You can see how large of a gap it leaves in the femoral condyle after you have removed it. Traumatic patellar dislocations, in contradistinction, most of them are able to be treated successfully, about 75% of the time closed. Occasionally, the other 25% that are treated surgically typically have an osteochondral fragment that needs to be debrided, usually done arthroscopically. In recurrent situations in children with open growth plates, the tibial tubercle osteotomies and stuff that are done in adults typically can cause shutdown of the physis of the proximal tibia, which is a very sensitive physis. So typically we'll do a lateral release and some form of soft tissue realignment in order to, including the semitendinosus tenodesis, in order to avoid the tibial tubercle osteotomy. OCD or osteochondritis dissecans is common in kids. The difference between the treatment of this in children versus adults is that commonly they'll heal in children if their physis is open. If they don't heal and they start to show signs of fragmentation, those are the children that need to have surgical management. The typical test answer, though, on a child who's 12 years of age or younger with open growth plates and an osteochondritis dissecans is to treat it with activity modification or casting. If there's impending fragmentation, and on the test they'll show you that an MRI showing that or an arthroscopic picture, then internal fixation is warranted. I saw one time in the last 5 years an Osgood Slaughter's question showing you the picture that I'll show next, which is a child with an enlarged tibial tubercle eminence and pain in the anterior aspect of the knee. From a pathological standpoint, what occurs is this is a microfracture of the tibial tubercle that happens over and over, typically in jumping or explosive type activities, sprinters, long jumpers, high jumpers, basketball players. And with repetitive healing of that microfracture creates a hypertrophic tibial tubercle, a bump such as this, and the activity modification, rest, and ice are the treatment options. Discoid meniscus is not a common problem to see, but readily testable. Usually they present with mechanical symptoms. They lack full extension of the knee. An arthrogram, which is obviously not very commonly performed anymore as with the MRIs available, will show that you have a definite thickening in the meniscus. Typically it's the lateral meniscus. When the meniscus is excised, you can see that there's definite lack of saucerization of the meniscus. It can either be partial or complete, and then it can either be stable or unstable. Popliteal cysts are rare to need treatment, but commonly present in the office and are also not uncommonly seen on an exam of mass in the posterior medial aspect of the knee in a child who's ambulatory and typically asymptomatic. Typically they'll tell you that it transilluminates and that the x-rays are normal. The treatment by and large is observation. Excision can be done in complicated cases, or if it's causing significant discomfort. It's not typically associated with meniscal tears like it is in the adult population. So I was going to do one more section, which is an infection prior to the break, and the infection section is less than half of the previous, so then we'll be about 60% done. So musculoskeletal infections in children, in my opinion, are quite easy from a testing standpoint. Obviously, I'm a little biased, but after I go through this, hopefully you'll agree with me. Osteomyelitis is where we'll start. Most commonly, the root is hematogenous. Through the bloodstream, some type of septic event occurs, and almost always it occurs in the metaphysis. That's where the arterioles come into the bone itself. They feed up to the metaphysis, and the sinusoids have a blood pooling effect, and that's where the bacteria can harbor. So the metaphyseal location is the most common. Most common organism by far and away is Staph aureus. As time goes by, they're becoming more and more resistant organisms, but Staph aureus is for sure the most common organism. The clinical picture for osteomyelitis, and remember this in contradistinction to what we're going to talk about next, which is septic arthritis. Typically these children have a limb that's swollen and tender. They may not want to walk on it, but they're not toxic looking. They're not septic looking. They're not deathly ill looking. They may or may not have a fever. They almost always have an elevated white count, almost always have an elevated SED rate and CRP. The hard part is almost always their x-rays are normal, especially early in the disease. So if you have a child with an ankle or a tibia that's swollen and red and erythematous, if it's spina bifida like we talked about earlier, you're going to think about trauma or fracture. If it's a normal healthy kid, you're thinking infection, you get an x-ray and the x-ray is normal. You can't just stop there. You have to get a bone scan because commonly the x-ray will be normal and the bone scan will have a hot spot where the early inflammation is starting to take hold in the metaphyseal region of the tibia. The diagnosis is made by aspirating it. You take a large bore needle, put it down to the tibial cortex. If there's a subperiosteal abscess, you can stop there. You have your diagnosis. If there's not, then you literally drill the large bore needle into the tibial metaphysis, aspirate into the tibia, and get your diagnosis that way. The treatment for osteomyelitis, if there's no pus in the subperiosteal region or in the metaphysis, and then it grows the bacteria on your culture, that categorizes as sort of a bone cellulitis type treatment or type phenomenon. Start them off on IV antibiotics and then convert them to oral antibiotics after they demonstrate a good response. There's no set time limit for IV antibiotics. It's when they have a good clinical response, when their fever comes down, the child's less painful, and then you switch them to oral antibiotics to send them home. In reality, the hard part is sometimes little guys like this, it's hard to get them to take the medicine. So one criteria for them going home on oral antibiotics is that the child has to be willing to take the medicine and the family has to be able to get him to do it. The other kind, in the other instance, if you put the needle in and you draw a pus, like you can see in this picture, from the tibial metaphysis in the subperiosteal region, you know you have a subperiosteal abscess. It's an abscess in the deep tissues, and that needs to be treated surgically. So surgically, you do an incision and drainage, put them on IV antibiotics, usually for a week until they have a good clinical response, and then switch them over to oral antibiotics. Total length of time of oral antibiotics is somewhere between 4 and 6 weeks. Septic arthritis, the picture you see on this screen is one, there are two routes that septic arthritis can occur. One is hematogenous, very similar to the osteomyelitis group. It can seed in a joint. Commonly, these kids will have an incidental injury, fell on the soccer field, had a bruise in his hip, had an upper respiratory infection, and now he won't move his hip. That's a typical presentation for septic arthritis. The other route is direct extension. You can have a metaphyseal osteomyelitis, such as in the hip. The proximal femoral metaphysis is intracapsular. So you can have a subperiosteal abscess that occurs if it breaks out of the periosteum, and then it'll seed the hip joint. So that would be a direct extension route of mechanism. So that leads to another test question. What joints have intra-articular metaphyses? And they can ask this multiple ways. One method they could say is, which joints are susceptible to having septic arthritis occur by the route of direct extension? That's another method of asking that same question. The hip joint I just showed you, this is a path specimen showing the capsule attaching distal to the metaphysis. The elbow, the radial head, the ankle, the distal fibula, the shoulder, proximal humerus, and the hip joint are the big four. The clinical picture with septic arthritis is much different. Remember before I told you had a child who maybe walked in or limped? A kid with septic arthritis won't walk. They sit like this on the table. If you even bump the table, they go through the roof. They don't want you to even, I always tell the residents, try to log roll the hip to see if you can gently move it, and if they'll let you do it. They don't want you to touch that hip. They're very, very fearful of you touching it because it hurts like crazy. If it's the knee, the same thing. They'll hold the knee flexed, and they won't want you to extend it. They commonly have a fever, elevated white count and sed rate, and also their x-rays are commonly normal, unless it's been ongoing for a while, in which case at the hip they can have, in most severe cases, they can actually have a dislocation of the hip, but they can get a widened hip joint if they have lots of pus within the hip joint. The treatment, once again, first you got to make a diagnosis. The way you make your diagnosis is you aspirate. You put your needle into the hip joint, and if you get pus like this, you have your diagnosis. Once you've made your aspiration, if I get this, to be honest, if I do a hip aspiration and I see that, then it's always a challenge between me and the resident to see if we can get the aspiration done, the joint open and drain and the wound closed before before the white count comes back from our lab. Because once you see the pus in the joint, you know you need to drain that hip. In fact, you send if there's any question, you wait until you hear back from the lab. You want to see if there's an elevated white count. Up to 80,000 is considered to be, 60 to 80,000 is the most common number you'll see for a septic joint. The numbers that get really crazy, up over 150,000, are typically more rheumatologic type disorders that'll cause that elevated of a white count. And obviously you do a gram stain culture of that so you can appropriately administer your antibiotics. The treatment, by and large, is mostly the irrigation and debridement. The antibiotics are exactly the same as they are for the septic arthritis, for the osteomyelitis, because it's the same flora of bacteria causing the problem. One caveat I would tell you about septic arthritis is that gonococcus is still the most common cause of septic arthritis in the adolescent population. Puncture wounds of the foot deserve their own special category. Typically, it'll go through a shoe or through a sock, or a stick through a shoe and a sock, or something of that nature. Pseudomonas is the bug you need to remember. Now, they don't always tell you it's Pseudomonas, although they might say it's a gram-negative rod, so you need to know that Pseudomonas is a gram-negative rod. Typically, they present with a swollen foot, and the x-rays commonly are normal early. What usually happens is these people present after having had the puncture wound a month ago, and they come back, and then we'll have some changes within the metatarsal head or wherever the puncture wound occurred if they have osteomyelitis. The treatment is almost always surgical debridement. They go in because there's usually either a piece of sock or a piece of grass or a piece of some foreign material deep within the foot that's creating the problem, and the Pseudomonas is there as well. And then you switch them over to IV antibiotics. To date, there's no great anti-pseudomolane agent for kids, but there are some that the ID folks are usually willing to put them on, and now they're more willing to use Cipro, at least in our institution, so we're able to switch them over to oral antibiotics. But I think still that the surgical debridement is the most important part of the treatment. The last part of the infection talk is discitis. Discitis depends on the age of the child as to how they present. A toddler is not going to come in and tell you, oh, my back hurts. They're going to come in and say they don't want to walk, or their belly hurts, because they refer everything to their belly, or they don't want to eat. As they get older, obviously, they can be more specific and tell you it's their back that's bothering them. But these kids will typically have a fever, abdominal pain, refusal to walk, irritability, maybe a little bit elevated white count and sed rate, but nothing dramatic. The pathology about what happens is very similar to the metaphysis of the long bones. They get an early reaction in the end plate region, which is comparable to the metaphysis of the long bones, which then can seed into the disc space. and that's most likely when it becomes symptomatic. After it's been in a disc space for a prolonged period of time, it can then infect or involve the vertebra on either side and create a vertebral osteomyelitis. The findings on the x-rays almost always are normal initially, especially within the first month. So if I'm suspicious of a child having discitis when they come in, you can see this child is 1.6, so 18 months old. If I'm suspicious for discitis in this child, I'll get an MRI, because when you get an MRI, you're able to categorize it, and you can see the disc changes consistent with the discitis. If on the MRI, it's early in the phase where they have no epidural abscess formation and no displacement of the fecal sac, I'll treat that child with antibiotics, brace or cast or something to calm them down. If they have an abscess, then obviously you need to drain it. Almost always it's staph that's the bug, and I do not aspirate these routinely, nor do I think most people do across the country. I treat with anti-staphylococcal antibiotics empirically, and if we get a good clinical response, I'll switch them to oral antibiotics for about a 6 to 8 week course, limit their activities with a brace, and have them move on after that. If there's no response to the IV antibiotics, or the symptoms don't improve, that's when I'll do the biopsy. And you can do CT-guided biopsies and things, but typically these occur in places where it's difficult to obtain your biopsy. The second section is a little less complicated, so we hopefully will be able to get through it fairly efficiently here, and I'll be happy to answer questions afterwards. The specifics of children's trauma are what makes the skeleton of the child a lot easier to deal with, is they heal quicker. They're much less likely to develop contractures from a long arm cast, for example, and they can remodel. The picture you see on the right here, they can take a almost 90-degree angulated humerus and through just normal growth, grow that deformity away. The basic principle that doesn't change is that fractures that go into the joint that are intra-articular need to be treated.